This is the Onco'Zine Brief with Peter Hofland.
In this edition of the Onco'Zine Brief, I talk with Dr. William Stern, a board-certified gastroenterologist and fellow of the American College of Gastroenterology at the Capital Digestive Care group outside of Washington, D.C., about advancements made in colorectal cancer screening. Also joining us today is Sue Spielberg, a patient of the Capital Digestive Care group. At the beginning of the National Colorectal Cancer Awareness Month, we talk about colorectal cancer and prevention of this form of cancer. One of the best screening tools to help prevent colon cancer is a colonoscopy. And colonoscopies are highly effective screening tools, considered the gold standard used to not only detect colon cancer, rectal cancer, and other conditions, but to actually help prevent these conditions from developing. Colonoscopies are very safe, but not completely without risk. However, and this is what every gastroenterologist, every oncologist, and in fact every physician will tell you, colonoscopies are done every day by experienced physicians. But more importantly, they will tell you that your chances of getting colon or colorectal cancer far outweigh the possibilities of complications from a colonoscopy. In our program today, we talk about one of the issues most patients undergoing a colonoscopy may find hard to deal with. It is what happens before the actual procedure, the preparation or prep. While different types of prep exist, the aim is always to empty the colon of fecal matter so that the doctor can view your colon clearly. Before your colonoscopy, your gastroenterologist is likely to recommend specific dietary changes in the week leading up to the procedure. Recommends that you stop taking certain medications that could increase the risk of bleeding during a colonoscopy, drink plenty of water or other liquids to ensure that you do not become dehydrated when you begin your prep, and drink an oral solution prescribed by the doctor to help clean out the colon. I'm Peter Hofland, and this is the Onco'Zine Brief. The Onco'Zine Brief is developed in collaboration with our online journal Onco'Zine at Onco'Zine.com, where you can find additional information and the latest news about cancer, cancer diagnosis and treatment, and cancer prevention. For more information on how to support our program, visit our website at Onco'Zine.com, and if you are living in the United States and want to receive our newsletter, text the word cancer, that is CANCER, to 66866. And we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. On the phone with me is Dr. William Stern of Capital Digestive Care Group outside of Washington, D.C., and Sue Spielberg, a patient of Capital Digestive Care Group who received a new PrEP treatment for colon cancer screening before her colonoscopy. Dr. Stern, Sue, welcome to the Onco'Zine Brief. Let me start by asking you, Dr. Stern, how serious is colorectal cancer, and is the disease preventable?
That's a very good question, especially since March is Colorectal Cancer Awareness Month, so it's very appropriate. Colon cancer is the third most common cancer in the U.S. and around the world, and the second most common cause of cancer death. So it's quite important. And unfortunately, it doesn't cause symptoms till it's very late on. But there is good news. The good news is that we know that colon cancer starts as a small growth called a polyp, and the polyp can take anywhere from 5 to 10 years to grow into cancer, which gives us a nice window of opportunity that if we can find polyps and remove them, we can prevent cancer. So that's the whole idea and strategy around preventing colorectal cancer.
If you look at prevention, a colonoscopy comes to mind. Now, how important is a colonoscopy in actually preventing the disease?
Very good question. Unfortunately, polyps, as I explained, grow into cancer, but they don't cause any symptoms themselves. So there's no way to find a polyp unless you look for them. And about 20 to 30% of people have polyps, so that's pretty common. There are several ways to look for polyps. The best way is a colonoscopy because you're looking right inside the colon, and it's the only way to remove polyps. So that's what most physicians recommend in terms of screening for colon polyps and colon cancer.
Here in the United States, there are national guidelines for screening. Now, if you look at people who qualify for a colonoscopy, what kind of age limit are you looking at? And what kind of people are you concerned about? People who really should consider scheduling a colonoscopy.
Very good questions. I just wanted to mention, as people may remember, the actor Chad Boseman died in the past year at age 43 from colon cancer, which he got at age 39. And Katie Couric's first husband, Jay Monahan, died at age 42 from colon cancer. So it can affect young people. The current guidelines from the American Cancer Society had been to start screening at age 50. But recently, over the last summer, they decided to lower it to age 45. But that's in people who have no symptoms and no family history of colon cancer. If you have a family history of colon cancer or colon polyps, where either of your parents or a sibling or a child have had colon polyps or colon cancer, we even start at younger ages. And then there are some people who have genetic predisposition who we may even start in their teens and 20s. But for the average asymptomatic person who has no symptoms, no family history, no risk factors, we now recommend beginning at age 45.
You also mentioned the fact that the guidelines are adjusted down from 50 to 45 years of age. Has that to do with the fact that colorectal cancer is now diagnosed earlier in younger people rather than only in older people?
Somewhat. I think it's because we're seeing it in younger patients. Thank goodness we're not seeing it in older patients because they're getting screened and getting their colonoscopies. So we have seen a reduction in colon cancer among older people. But we are starting to see colon cancer in younger people, and that's why they reduced the age. But remember, those are when people have no symptoms. If you have any symptoms, rectal bleeding, unexplained stomach pain, abdominal pain, unexplained weight loss, change in your bowel habits, those would be reasons to discuss with your doctor to do a colonoscopy even at a younger age.
Now, let's look at people that are younger and may not have any symptoms. I mean, of course, when you have symptoms, the first thing you do is go to your doctor and have it checked out. That's obvious. But if you're younger, say 45 years of age, what would be the reason you're diagnosed with colorectal cancer at such a relatively young age?
Well, some of them are because they have a family history. As I mentioned, that's a risk factor. Some people carry a gene that's a risk factor. Just like the BRCA gene affects breast cancer, there are genes that affect colon cancer. And that would be the main reasons why younger people might get colon cancer.
At the beginning of the program, you mentioned that a colonoscopy is definitely one of the best tools to be used in terms of making sure that you see what's going on in the colon. Unfortunately, people are not always feeling comfortable with the idea of a colonoscopy. I decided to opt out. What would you say to those people?
Well, I'd say that over the years, and I've been doing this for almost 30 years now, it's gotten better in terms of the sedation that we use, the preparations that we use, so that most people, when we wheel them back into the recovery area after the colonoscopy, ask whether it's been done yet because it's so comfortable. You fall into a sort of a mild sleep state. You're still it's what we call monitored anesthesia care. It's very mild anesthesia, but the procedure is very safe and comfortable. I think the part that gets people most concerned is the preparation, because that you have to clean out the colon in order to be able to see anything. And so that's gotten better over the years also.
What would you say to people who are concerned, maybe concerned about the preparation? There are a number of commercially available alternatives to colonoscopy. What would you say about people who are considering these alternatives?
Right. So there are a couple of other ways that people are screened. The most important thing is to get screened. There are special stool tests, bowel movement tests that have been refined to look for the DNA from polyps and cancer. When they test all these alternatives, they developed a blood test to look for cancer. When they want to see how good these alternatives are, they compare them to colonoscopy, because colonoscopy is considered the gold standard. Unfortunately, those tests often can only find cancers and can't find the precancerous polyps. And we really would like to find those and remove them in order to prevent cancer.
Let's take a short break, and then we're back with Dr. William Stern and Sue Spielberg.
Did you know that generic drugs are just as safe and effective as brand name drugs? Generics might look different, but they work the same way. And they can even save you money. Don't believe me? Ask your doctor or pharmacist. Or visit fda.gov/generic drugs.
Sarcoma. Odds are you've never heard that word before. But for the 40 people diagnosed with sarcoma every day, it is a life-changing word. Life-changing and devastating because sarcoma is cancer. Sarcoma is a cancer of bone and soft tissue more prevalent in children than in adults. More than 6,000 people lose their lives to sarcoma each year. Treatment options for sarcoma are limited, and new therapies are desperately needed. More research and increased awareness is necessary to find a cure for a cancer that you probably didn't even know existed until now. Through awareness, advocacy, and research, the Sarcoma Foundation of America is determined to help those affected by this forgotten cancer, to bring hope to the children and adults whose lives are forever changed by a word they had never heard before. Please help us in the fight to find the cure for sarcoma. For more information on sarcoma and the work of the Sarcoma Foundation of America, please go to curesarcoma.org.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. In today's episode of the Onco'Zine Brief, I'm talking with Dr. William Stern and Sue Spielberg. I'm Peter Hofland, and this is the Onco'Zine Brief. So basically, it goes to the fact that the earlier you'll find something, the better it is. And in the case of some of the alternative, you may be too late. Is that what you're saying?
Well, if even colon cancer, when it's found, if it's found early, is often curable. And like I said, people should still get screened. Most of these other tests, because they're not as accurate as colonoscopy, have to be done more often. The stool tests either yearly or every 3 years. If you have what's called a CT colonoscopy, which is done with a CT scan, that's every 5 years. In the asymptomatic average risk patient, you only have to do a colonoscopy once every 10 years. So it's not something that has to be done every year or even every other year. Even if we find polyps in patients, we often can go either 3 to 5 years, just depending on the size of the polyps and the number of polyps. So it's really good preventative medicine.
You're talking about preventative medicine. What if people say, I'm opting out because I'm not insured? Is that a good reason not to consider a colonoscopy?
Well, most states, I'm in Maryland, so I can only speak about Maryland, has a pool of money to screen patients who are not insured. So there are ways for people who even aren't insured to get colonoscopies done. It's thought to be such an important preventative medicine act. It's covered, if you do have insurance or Medicare, it's covered under every plan as preventative without any copay and without any deductible.
Right. So the argument is not necessarily a good argument.
Correct. Mm-hmm.
Now, you mentioned the prep. The preparation might be very uncomfortable for some people, but there are some good alternatives that make it easier for people to accept this prep. Can you tell me a little bit about this?
Okay, so the traditional prep, let me back up first. Unless the colon is clean, we can't see anything. And it really has to be pretty much spotless. Otherwise, we won't be able to identify very small polyps. And also, the procedure isn't as effective or technically able to do if the colon is dirty. So the traditional preparations involved being on a clear liquid diet for a day or two and then taking a number of laxatives. When I first started doing this, we would give patients a gallon of liquid to drink. Over the years, it's come down, but what patients complain about is, they have to take a dose at night before they go to sleep, and then they have to wake up 4 or 5 hours prior to the procedure to take the second dose, so they don't get a good night's sleep. They start running to the bathroom all the time. If it's once in 10 years, it's certainly doable. But we've come up, not myself, but companies have come up with an alternative prep where you come in the morning of the procedure and sit in a spa-like chair, and a small tube is put in the rectum, and your colon is gently washed out from below. So that's relatively new, and we just started doing it at the beginning of this year in Capital Digestive Care in Rockville, and there are 4 other places around the country that do it. But there is good patient satisfaction with this as an alternative.
Now, when you talk about this alternative, does that mean that people are not required to start adjusting their diet and drink a lot of water in the week before their scheduled colonoscopy? Is that correct?
It's partially true. We still ask patients to stay on a clear liquid diet the day before, and we give them some Biscadil or Ducalox tablets to take the day before, but there's none of that liquid that you have to drink, and you don't have to get up in the middle of the night for the second dose.
So, if I have to interpret that for the patient, this would be a much gentler way and a much more comfortable way to prep for a colonoscopy.
Yes, I believe so. We have a patient on the line who can describe it, and I'm getting my own colonoscopy in a few weeks. I'm going to use this prep, so I'll be able to tell you firsthand, too.
Sue Spielberg, welcome to the Onco'Zine Brief. I understand that you have experience with colonoscopies. It's not your first one. You've had multiple colonoscopies over the years. Now, can you tell me a little bit about the prep that Dr. Stern was talking about?
It was the prep that I had this time. This was the third colonoscopy. Was just a world of difference for me because I had a really hard time drinking the liquids on the others, and a lot of nausea, and just and then being up all night and very uncomfortable. This was so much easier. It was an odd feeling, kind of thinking about this big spa-like toilet tub unit, but it was very comfortable, especially when seated and with a warm blanket, and my modesty was intact. And it was more of a mental adjustment because it was something different, different sensations, but I came in well rested because I hadn't been up all night pooping. And then it was just this warm water flow, not really pain, but just a rhythmic kind of fill up the colon and a gentle urge to push. It wasn't a painful stomach cramping type of thing that can happen when you take diuretics and things, right? It was a very positive experience, I highly recommend it.
Right. That was my next question to you. If someone who needs to schedule a colonoscopy and may have some fears, would you talk about the alternative, not as a doctor, but from your own patient's perspective?
Yes, I think it was definitely a good alternative for somebody, especially a younger crowd, who will not have to lose a day of prep time and feeling kind of rotten for 1 or 2 days before. It was you have to commit to that sometimes with the older methods. But this was just a really easygoing procedure, and it was, I didn't experience any ill effects, and it was very just easy enough going from the prep unit over to the surgical care unit was in the next building, so it made it very convenient. The timing worked, it coordinated well, and the liquid diet the day before wasn't nearly as difficult because I didn't have to drink any of the prep stuff, and just drinking lots of water helped also. I just followed the instructions, which were pretty simple to follow. So this was, to me, a no-brainer to try.
You've tried this alternative. Now, looking back at the other colonoscopies you've had, when the care team at Capital Digestive Care Group approached you and told you about this opportunity, were you not just a little bit skeptic?
Well, it's interesting because I actually sought it out because I saw Dr. Stern had posted something on Facebook that it was coming about a year before. And I followed up with my doctor in the care, same, Capital Digestive Care. And he said, I think you'd qualify when it opens. We'll put you down, and as a person, we'd like to try it. So I kind of pursued it because I just thought it sounded much more comfortable of a procedure than what I'd had in the past. And I had experience with my past two just being very miserable with drinking and, having that kind of prep. So yeah, I kind of sought it out, right, Dr. Stern? I think I asked you about it back then.
Dr. Stern, let me go back to you. You had some questions for Sue.
I was just going to ask Sue to explain, because you had asked about the colonoscopy itself. Sue, how did you experience the colonoscopy? Did you have any discomfort or pain during or after?
No, it was a little propofol, and the next thing I know, I was up and feeling fine. I mean, it's just the only thing that happens to me afterwards, a little bit of bloating, and it passed pretty quickly. I went back to pretty much normal bowel habits within the day, and didn't experience any pain or any uncomfortableness at all. It's when somebody gives you a little shot and then says, "Have a nice nap," and next thing you know, you're up and very alert. You don't feel drugged. It was pretty. It seemed like it all passed within seconds, but it's an interesting process. I didn't have a problem with any kind of pain from that at all. No uncomfortableness.
People shouldn't be concerned or afraid of the procedure from that standpoint.
No, it's really pain-free. It was not uncomfortable at all. No.
Let's take a break. If you're just joining us, March is the National Colorectal Cancer Awareness Month. And in this edition of the Onco'Zine Brief, I'm talking with Dr. William Stern, a board-certified gastroenterologist and fellow of the American College of Gastroenterology at Capital Digestive Care Group outside of Washington, D.C., and about advances in colorectal cancer screening. And we're joined by Sue Spielberg, a patient of the Capital Digestive Care Group. I'm Peter Hofland, and this is the Onco'Zine Brief.
Over the years, you've brought opioids into your home. They helped when you were in pain, and you held on to them just in case. But holding on to opioids puts your family at risk. Learn more at www.fda.gov/drug disposal.
Most of us like to be out in the sun. That's why sunscreen and other safety measures are key to protecting your skin from aging and cancer. The FDA recommends using a sunscreen with a sun protection factor, or SPF, of 15 or higher. Also, look for broad spectrum on the label. That means both harmful ultraviolet A and B rays are blocked. UVA rays age the skin, UVB rays burn, and both cause cancer. But the perfect sunscreen doesn't count if you use it wrong. Don't need sunscreen on a cloudy day? Wrong. 80% of UV rays still get through the haze. Only use sunscreen at the beach? Nope. Anytime you're outside, UV rays attack the skin, so you need protection. And you have to reapply sunscreen every 2 hours. Remember, SPF plus broad spectrum equal healthy fun in the sun. Visit www.fda.gov/sunscreen for more information. A message from the U.S. Food and Drug Administration.
This is the Onco'Zine Brief with Peter Hofland.
Welcome back. This is the Onco'Zine Brief. If you're just joining us, in today's episode of the Onco'Zine Brief, I'm talking with Dr. William Stern, a board-certified gastroenterologist and fellow of the American College of Gastroenterology at the Capital Digestive Group outside of Washington, D.C., and Sue Spielberg, a patient of the Capital Digestive Care Group. That is good news about colonoscopies, of course. If it can be done pain-free, that's fantastic. And the fact that there is now a new method to prep that is not uncomfortable and makes it easier for people to consider a colonoscopy. Dr. Stern, you have mentioned that this is a relatively new option. So where is it available?
Right. So the prep is called Hygieia Care, and that people can go to their website or go to our Capital Digestive Care website, and it links to information about Hygieia Care. It's now in 5 places. I believe it started in Austin, Texas, and Bee Cave, Texas. That's one center, one in Ohio and Cincinnati, one in Jackson, Mississippi, one in Norfolk, Virginia, and we're the newest one in Rockville, Maryland. So it's slowly spreading around the country as people are getting more familiarity with it. I first saw it at one of our gastroenterology meetings about 5 years ago, and had interest in and followed up with the people who got it through the FDA. It is FDA approved. And over the years, we decided to open one up here in Rockville.
And in addition to offering your patients this new option, you're still offering the traditional colonoscopy and prep. Do you see people that come to your clinic opting in for the new approach, or are people more conservative and skeptical about the alternative prep option?
Right. So, in general, if patients of mine have had prior colonoscopies and didn't have any problem with the prep, we tend to continue with the traditional prep. It's patients like Sue who, didn't enjoy that first prep, or patients who look at it and say, I don't think I want to do that. And then we have patients who had a poor prep previously, either because they couldn't tolerate the solution or because it didn't seem to work, that come over for this, as we can be more assured that we'll get a good prep at the end of the process.
Now, we talked about colonoscopies and why they are important, but what would you say as a physician to people who really don't want to consider this?
Yeah, I think, again, we need to get people screened. So whatever works to get them screened is best. In fact, we have in our large group, we have about 6 or 7 different kinds of oral preps or traditional preps that can be done listed on our website. We often will let patients pick one that they think tastes better or looks better. But it's a patient who either, I don't try to encourage patients to do this new prep unless they've had a problem with the other one, or if they've sought it out like Sue did, or they've had a poor prep previously. I think it's just an alternative. I don't think it's, necessarily for everyone, but certainly people who've had problems with prior preps or were not cleaned out well before should certainly consider this.
And from a patient perspective, Sue, if I may ask you, what would you want people to know?
If somebody has difficulty drinking that much liquid and following the regime and feels apprehension about that, the lack of sleep and being up all night and running to the bathroom, it was just kind of a relaxing way to go into colonoscopy, because there's always going to be a little nervousness and stress of being put under, even though it's very light anesthesia and all that. But the whole experience for me was just more relaxing, because I didn't go into it with having lost a night of sleep and being anxious about that too. So for people who are working and don't want to have to worry about it, just go in and do it all in one time, although you did have to do the liquid diet the day before. But it's just, the whole procedure to me was just more positive than I'd had in the past 2 times. So I would advocate for it for people, especially who could not get cleaned up completely. I also think for anyone who's constipated, who has some chronic issues with that, this might help, with that. I don't know if that's something Dr. Stern's group is doing also, but...
I could mention that very briefly. We also use this machine or this spa chair for people with chronic constipation, even when they don't need to have a colonoscopy. We have patients who come in once a week, once every month to get cleaned out, and it's a good alternative to using harsh laxatives. That's just a sort of side note. We call that hydro relief as opposed to hydro prep.
Right. In both cases, of course, it is very important to clean out the colon. But I think that people who are constipated may have had other problems as well.
Yep, that's correct. We don't have to, when we use the hydro relief for chronic constipation, they don't have to be squeaky clean like for a colonoscopy. So it's just getting basically the bowel emptied, and patients feel so much better afterwards.
Now, March is National Colorectal Cancer Awareness Month. And during this month, we talk a lot about diseases of the colon and rectum, and for patients to get to know more. But this month is also important for physicians. It is an opportunity for physicians to learn more about colorectal cancer and ways to avoid it, and ways to also screen for it. Now, Dr. Stern, you are working as a gastroenterologist, and you are no doubt well informed. But if you are in general medicine, as a primary care physician, what are some of the key things you want a primary care or family physician to know about colorectal cancer and prevention? And what should they say about colorectal cancer and prevention to their patients?
It's a good question. And, most physicians are using computer-based systems to record their notes, and they often have in there reminders of what a test should be done at what ages. And colonoscopy is in there. So that helps remind the primary care or family physician to recommend to their patient, to get screened. And I think they need to emphasize the importance of prevention. In fact, this is the only cancer where we actually remove a precancerous tissue. When we screen women with mammography, we're looking for very early breast cancer, not precancer. When we screen women for cervical cancer with Pap smears, it's looking for cancer itself. When men get prostate exams, we're looking for cancer. But in colonoscopy, we're actually looking for the polyp, which is not yet a cancer. So we're actually a stage before, and that's why it's been so beneficial in reducing colorectal cancer.
Now, let's talk a little bit about this polyps. When people hear the link between colon cancer and polyps, and if they have polyps removed, should they worry that the fact that if they have polyps in their colon, that every polyp automatically leads to the development of colorectal cancer? Should they worry about that?
That's a very good question. There are two main types of polyps. Don't want to get too technical, but one type is called an adenoma or adenomatous polyp. That's the kind of polyp that does lead to cancer. And there's another type of polyp called a hyperplastic polyp, which doesn't. And they can both be found in the colon. And if you have a colonoscopy and hyperplastic, the non-precancerous polyps are removed, you get to go a full 10 years to your next colonoscopy. If you have the adenomas or the precancerous polyps, those are the ones that we recommend repeating it 3 or 5 years, depending on the size of the polyps and the number of the polyps that we find.
Right. And in both cases, it is something that you will be able to discover or see during a colonoscopy?
Well, we actually remove the polyp and we send it for a biopsy. So although we can be pretty accurate by looking at it, they do have different appearances. We do remove the polyps, all polyps, and send them for biopsy. And then that gives us the definitive answer of which kind of polyp it is and when the patient should come back for their next colonoscopy.
Let's take a break. If you're just joining us, March is the National Colorectal Cancer Awareness Month. And in this edition of the Onco'Zine Brief, I'm talking with Dr. William Stern, a board-certified gastroenterologist and fellow of the American College of Gastroenterology at Capital Digestive Care Group outside of Washington, D.C., and about advances in colorectal cancer screening. And we're joined by Sue Spielberg, a patient of the Capital Digestive Care Group. I'm Peter Hofland, and this is the Onco'Zine Brief.
Clinical trials allow researchers to introduce new hope by providing participants access to cutting-edge and potentially life-saving treatments. Speak with your doctor and visit standuptocancer.org/clinical trials to learn more. Together, we can stand up for all of us.
The Centers for Disease Control and Prevention is encouraging cancer patients and survivors to be extra cautious during the COVID-19 pandemic. Cancer treatment, especially chemotherapy, weakens the immune system, making you at higher risk of severe illness. Dr. Lisa Richardson is director of the CDC's Division of Cancer Prevention and Control.
Take these steps to stay healthy. Wash your hands often with soap and water. Clean and disinfect frequently touched surfaces daily. Stay home. If you must leave, keep at least 6 feet between you and others. Avoid touching your face, eyes, nose, and mouth with unwashed hands. If your temperature is 100.4 or higher, call your doctor. Use CDC's coronavirus self-checker to help you make decisions about seeking medical care.
Make sure your caregivers and household members are aware of your higher risk and take precautions. Visit cdc.gov/coronavirus and preventcancerinfections.org for more health tips.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. In today's episode of the Onco'Zine Brief, I'm talking with Dr. William Stern and Sue Spielberg. I'm Peter Hofland, and this is the Onco'Zine Brief. Now a different question. We're still in the middle of a COVID-19 pandemic. How does that impact your work? Does it prevent patients from coming to the clinic? If they are about to, or if they need to schedule a colonoscopy, should people worry about that? How do you prevent people from getting infected when they come to the clinic?
Well, everyone should be concerned about COVID-19. What happened in our situation, from March till June, we only really did emergency procedures. We stopped doing routine screening. I think that was in general for everyone, mammographies, pap smears, colonoscopies. By the time we got into the summer, the American Cancer Society and most medical societies were concerned that if we stopped screening, we're going to be seeing more cancer, so that we developed very safe techniques. In our situation, we started doing routine screening in June of last year. And what we did, and some other places do, is we test all our patients for COVID 2 to 3 days prior to the procedure. And our practice actually has a lab that can process the COVID specimen, so we get the result overnight. Because the worst thing would be is to tell a patient they have COVID even if they have no symptoms after they've taken a PrEP, whatever PrEP it is. So we want to make sure to get them the response beforehand. And what we're doing with the doctors and the staff, we're getting tested for COVID every 2 weeks. At this point, all the doctors and most of the staff have gotten their vaccine. The other thing is that we don't do any COVID or sick patients in the outpatient facility, and we do it in an outpatient non-hospital facility. So all those things taken together since June up until now in our practice with 7 different divisions have done over 15,000 patients without any COVID infection. So it is very safe, and patients should not put off getting screened because of that concern.
And that was my story with your practice, because I was nervous. This first time I'd really been out to do a procedure during the pandemic, and I was given the test, the test first in advance, and then walking indoors for me was psychologically difficult because we hadn't really gone anywhere, but everyone was masked, and then once there, I felt very comfortable.
Right. So if people would like to use COVID-19 as an excuse to put off scheduling a colonoscopy, you would do everything to help them understand that you and your team are doing literally everything to make sure that people do not have to worry about getting infected with the virus that causes COVID-19 in your facilities, and that they should not use COVID-19 as an excuse to postpone screening. Is that correct?
Yep. I think you'll run the risk of missing a precancerous lesion, so it's important to get screened.
Now, last year, the American Society of Clinical Oncology, the American Association for Cancer Research, and the American Cancer Society, all big organizations in terms of cancer research and information about cancer, they were alarmed about the fact that if you stop screening as a result of COVID-19, you may run the risk of seeing an explosion of people being diagnosed with colorectal cancer later. How concerned are you about that?
Well, that's a concern. Unfortunately, we did see that with people with heart attacks and strokes. We're afraid to go to the hospital, and there was a higher incidence of out-of-hospital mortality and morbidity for patients with heart attacks and strokes. So obviously, that's a more immediate problem. The preventative medicine like colonoscopy, mammography, pap smear, is a more long-term, but I think most people now feel comfortable, and as Sue mentioned, we're getting a lot of people coming in for their first colonoscopy and their follow-up colonoscopies, and personally, I've had very few, if any, patients who have decided not to do it because of COVID.
Right, and I think that this is a good end of our program today. If I sum it up in this way, if you are 45 and older, you should not put off colonoscopy. If you're in a risk group, or if you have a familiar history with colorectal cancer, or there may be a genetic profile that indicates a link with colorectal cancer, don't put off scheduling a colonoscopy. Are these the messages that we should expect this month during the National Colorectal Cancer Awareness Month?
I think you summed it up perfectly.
And Sue?
I was going to say the same thing. That's exactly what I would say. Yeah, don't put it off.
Well, thank you both for being with us here at the Onco'Zine Brief. I hope that our conversation this morning helped some people to realize that a colonoscopy is not painful, and that there are ways of making the PrEP much more comfortable, and that they should not use COVID-19 as an excuse to postpone a colonoscopy. Thank you very much.
Oh, absolutely.
Thank you for
if anyone has any concerns, they should speak to their physician and allay their concerns. But thank you very much, and thank you for helping us get the word out.
Thanks for having us.
In today's edition of the Onco'Zine Brief, I spoke with Dr. William Stern, a board-certified gastroenterologist and fellow of the American College of Gastroenterology at Capital Digestive Care Group outside of Washington, D.C., and Sue Spielberg, a patient of the Capital Digestive Care Group, about advancements made in colon cancer screening. For us here at the Onco'Zine Brief, we want to thank you, our listeners, sponsors and advertisers, for your ongoing support. Your support makes it possible that you can hear this program via PRX Public Radio Exchange and in the United Kingdom and mainland Europe via UK Health Radio. And you can also download our program via podcast and streaming media, including iTunes and Spotify. For more information about supporting the Onco'Zine Brief, go to Onco'Zine@Onco'Zine.com. If you're living in the United States and want to receive our newsletter, text the word cancer to 66866. And we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. Thank you all, and thank you for listening, and join us again for our next episode. I'm Peter Hofland, and this is the Onco'Zine Brief.
The Onco'Zine Brief is produced by Sun Valley Communication in association with Physicians Weekly and the American Association of Medical Education. Support for the Onco'Zine Brief comes from listeners of this station and our commercial underwriters and advertisers. For more information about advertising, underwriting, and sponsoring options, visit Onco'Zine at www.onco'zine.com/underwriting. The Onco'Zine Brief contains health and medical-related information and is provided for educational and entertainment purposes only. The content in this program is not intended as a substitute for professional medical or health advice and does not replace your doctor's advice and guidance. Your doctor is the best person to answer questions about your personal health. If you hear something in this program that doesn't agree with what your doctor has told you, ask him or her about it.